Hello, hello. Today we will discuss the important topic of the relatives in the ICU. And we have a world expert with us, Professor
Hello.
Elie Azoulay from Paris, who has lots of ideas about it, and he has published a lot on this. He is, as you probably know, the president-elect of our European Society. Elie, hello, hello, my good friend.
Hello, Jean-Louis. Good to see you.
So we have about 10 questions to you, and they will be related to the visits in the hospital, to the communication with the relatives. We'll speak about the after the ICU care. We will speak a little bit about end of life issues, of course. And also, why not? A little bit of COVID at the top of it. It's difficult not to put
It's
it
the time for it.
in it. My first question, Elie, will be about the visiting hours. We are all moving towards open ICUs without visiting hours, right?
Yeah, that's true. And there are two kind of opening ICUs. One is extending visiting hours for many more hours and many visiting slots, because we are all aware that if we are limiting ICU visits, we are also putting burden on family members, but also on patients and caregivers. But there are also 1/3 of ICUs in Europe who are now with open visitation policies with no actually any restriction, 24 hours visiting. It can be the day, the night, or at any time of the day. So that's true.
Now, can you elaborate on the reasons why there were visiting hours in the hospital? Is it something logical?
Yeah, I think that there's a history about it. And so first of all, many hospitals had restriction visiting hours for quarantine. At the time, there were pandemics in the 19th century,
Yep.
and we are very far from that. And lately, at the end of the 20th century, we had less visiting hours, but for some of them, it was about patient safety and healthcare provider safety. And at many places, they were with restricted visiting hours just to give time for care to ICU clinicians. So at the end of the 90s and at the beginning of the 21st century, we started to understand why these visiting hours were actually harmful, not only for family members, but also for patients and for healthcare providers, and we changed the model.
Yeah. Now let's move into the future then. With the COVID experience, aren't we using more telecommunication? And in the future, won't we communicate more via our iPad or other systems, smartphone, etc.?
Yeah, in the global world, I think that for sure we will extend our ability to communicate through new media. It can be digital. It can be what you just referred to with iPads, iPhones, tablets, smartphones, etc. But I think that is not going to replace the true visiting hours and the reality of the communication that has to be face to face for some of the threshold moments. We know now that even if we develop digital communication, I think it can be an ad, but it cannot replace the face-to-face communication.
Now, a main obstacle to open visits have been the nurses, and in particular, they are concerned about people going in and out and looking at other patients and interfering with their work. Do you have rules in your department? Do we have a list of rights and duties?
Yeah, I think that we have two kinds. We have one that are institutional, that are related to the hospital, and we have ours in the ICU. So in the hospital, for example, teenagers cannot visit, or sometimes you cannot visit at the time for COVID, but we are bypassing this really, and we extend visiting hours with no visiting time and no real limit in the number of people visiting. There's a very nice Italian study showing that in a crossover design, that when you are opening the ICUs, there are more bacterial and sometimes fungi in the air or on the surfaces, but no increase in the number of ICU-acquired infections.
Yeah.
And these results were quite reassuring.
Yeah, but do you have some rules somewhere that the nurse could refer to saying, there is too much noise, or you are too numerous in the rooms, or the patient should rest, or whatever? Do you have
I think that we have rules to manage conflicts. When there are conflicts between family members and the healthcare team, so there are rules that are limiting not the opportunities for the time we are solving the conflict, the opportunities for interactions when there's a conflict. But the reality is that when we open the ICU visits, we have less conflicts. We have less people in the waiting rooms.
Yeah, so it's only in case of conflicts that you have your your rules. Yeah. Are the relatives invited to contribute to the care of the patient, feeding or toileting?
Yeah, I think it depends on the ICU. I just want to emphasize that if someone has to take care of the patient, you just need to restore the normal care. So if one of your friends is coming to visit you in the ICU, he's not going to make you a shampoo if not something that he or she was doing before the ICU. So what we do, we are restoring a normal relationship between the patient and the relative.
Yeah, right. Do you think that the presence of relatives can decrease the incidence and the severity of delirium?
Yeah, there are many data about it. There are pediatric data that are only from observational studies. When the parents are here, there is less anxiety, less pain, and less agitation. But there is this wonderful Brazilian study that has been published in JAMA, last year, that reported then when you compare two clusters of ICUs, one with open visiting hours to the other one with restricted visiting hours, you have more family delirium with restricted visiting hours. So yes, I think that the presence of family members is very reassuring for patients, and that there are more data that we should gather on the use of sedation when family members are more present.
Yeah. Now, you published on ICU diaries. Do family members contribute to it, or does it help them after the ICU stay, as it may help the patient?
Very briefly, I want to remind that the ICU diary was designed to fill in the gap that we are bringing to patients with the use of sedatives, with benzodiazepines. So normally, the diary is supposed to fill in the gap for the patient, to reduce post-traumatic stress disorder based on delusions. But for family members, there is no strong background to say that is going to be helpful for them. And the randomized control trials that was performed in France by Maïté Garouste and co-workers was negative. So I think that we should consider that for this kind of trials, instead of producing negative trials, we should consider maybe a better endpoint to understand what are the strengths from diaries. And I would not be shocked to use a qualitative endpoint in this kind of trials.
Yeah. Now, in a number of departments, they have post-ICU visits for patients primarily.
Sure.
Is it important for the relatives to join them and contribute to these discussions after the ICU stay?
You raise a very important point, Jean-Louis. We also have the post-ICU visits for family members, because there are many papers now showing that for the following, after ICU discharge, family members of RDS patients, for example, might be more severely impaired than patients themselves. So we also do post-ICU visits for family members. So yes, I consider that only ICU specialists, nurses and doctors are able to understand the ICU experience from a perspective of patients and relatives. So yes, I think it's very important.
One word about end-of-life issues. Let's say, I know you like conferences with family members. That's my first question. You prefer not to discuss these aspects plic ploc, as we say, at any time during the stay of the patient in the room. You like to have conferences, right?
Yeah. So yes, we worked with Randy Curtis from Seattle in the United States, and he designed an intervention that is based on a very nice literature showing that point by point, the value mnemonic is associated with more family benefits. For example, more satisfaction, less anxiety, less depression. So we took the example of anxiety, depression, and post-traumatic stress disorder by designing a randomized control trial using the mnemonic. And yes, the family conference are also the legacy from the support investigators. You remember, Jean-Louis, in 1995, the support investigators published a negative trial saying, instead of doing things, we should be proactive and go to family members. And this is what the family conferences are actually doing. And Randy Curtis were really right. When we do that in a setting where it's not part of the standard of care, we are actually reducing anxiety, depression, and post-traumatic stress disorder for family members who are unfortunately bereaved.
Yeah. Now, if there is a conflict with the family, and in particular when you think that things are over, the patient will never recover any good quality of life, the family doesn't want to hear you. Do you have a secret, or is it talking, talking, talking?
But talking is a secret, but the real secret, yes, I have one. It's listening to family members. I think that when we sit with family members, we do
Yeah.
the day three conference. We try to understand the family balance, and usually when there's a conflict, there's also an inside family, an intra-family conflict, and not all the family members are in the same line. Understanding this balance is really a key to solve the conflict. Of course, it's not a miracle, but it helps in many situations when you try to understand that one of the family members has actually a conflict with his or her own family. So this is one. And two, yes, I think that listening to family members is a very good way to provide them opportunities to ventilate emotions and to bring concerns to the eyes of nurses and doctors in the ICU.
Yeah, absolutely. These are very good points. My last question is about COVID. We need to say something about COVID. And you published a very nice paper in the JAMA recently on the relatives' thoughts when someone dies in the ICU and how we could perhaps improve that situation. Any comment?
Yeah, in my group, Nancy Kentish-Bartz, who is a sociologist, has brought to our research group qualitative research. So she is leading another group of psychologists and healthcare social workers who were doing semi-structured interviews and identified domains that are important for family members. And in bereaved family members at the time of COVID, this concept of stolen end of life, because with deprived family members, not only for the time patients was in the ICU, but also at the end of the life, they couldn't say goodbye. And we know that this is a real source of complicated grief. And they couldn't be really aware of the situation at the time of it. And even for the funerals, unfortunately, family members didn't have the opportunity to do that very well. So yes, qualitative research, and Nancy Kentish-Bartz is one of the leading experts about it, are actually adding to what we do usually as ICU physicians, more observational and more trials. And I think that this qualitative research is really giving thoughts and is raising hypotheses that have to be now checked in future trials and in future large observational studies.
Yeah, yeah. In the past, qualitative research was neglected and considered as lower level science.
This time is over.
We learned a lot from qualitative research. Our time is already over. It was very interesting, Elie.
Thank you. Very happy.
Thank you very much on behalf of everybody. And thank you
for
participating.
Thank you very much.